Welcome to the Helen Bader Foundation CBRF training program. You are now watching Part 2 in the Normal Aging versus Dementia unit. Part 2 is entitled, What is Dementia? I'm pleased to introduce Barbara Lawrence, Program and Community Services Director for the Alzheimer's Association of Southeastern Wisconsin. Barbara is a nurse whose background includes 10 years of staff development in long-term care facilities.
Thanks, John, and now I'm going to introduce you. This is John Kupla. John is a social worker with a strong background in caring for people with Alzheimer's disease who live at home as well as in nursing homes. Presently, he's the education coordinator with the Alzheimer's Association of Southeastern Wisconsin, where he coordinates educational conferences, trainings for nursing homes and group homes, and provides technical assistance. We will start the unit with the pretest. Remember, the pretest and the post-test are both the same test, and you will not be graded on them. Your responses will be reviewed after you have taken the post-test at the end of the unit. Turn off the videotape and complete the Part 2, What is Dementia pretest in your workbook. Welcome back. John, I'm sure you've had experiences where you've been afraid because you've forgotten something, and maybe it's happened more often than usual. An example might be that you've had a meeting scheduled for weeks and you forget to go. Then somebody said, how could you have forgotten this? You scheduled it, way ahead of time so you wouldn't forget. And It can be embarrassing and sometimes frightening.
Definitely. Barb, you can probably relate to this situation. I'm going to talk about when you might have lost your glasses and you've been looking at them for some time and you realize they're right on your head. We have a slide on the screen showing a woman that's doing that right now.
Yes, I certainly can relate to that one. And then sometimes you can be in the middle of a conversation and forget where you were going with your thought, and you have to have somebody else redirect you to what you were talking about. This happens to all of us. Many of us will have this happen and become frightened, and other people realize that it's just maybe because they're on overload, they may be stressed. But it is normal for these things to happen. For a person with dementia, these situations may happen more often. Can you give us some explanation of what dementia is?
Sure, I'd be happy to. Barb, I'd like to tell you about what is dementia. I think it's important to realize that dementia is a disorder of the brain. It's a loss in mental abilities, and it's a severe enough disability to interfere with a person's daily life. The majority of adults over 65 don't develop dementia. And I think when we're working with older adults, we need to remember that it isn't normal for people over 65 necessarily. And in fact, only 11% of those over 65 develop dementia. So when you look at the total population, that's actually a pretty small percentage. Mm-hmm. It's important to remember that dementia is not a part of normal aging. And it can be a condition of its own or a symptom of a disease or illness. We work with many folks that live a very normal life into their very old age. And I think one of the classic examples is George Burns that we saw that lived over 100 and still was pretty fast to give a joke or to...
He certainly slowed down as he aged, but he was certainly still very vital until the end.
Absolutely. I want to tell you, Barbara, about two types of dementia. And I think it's important to remember that there are two types of dementia. The symptoms of the dementias are the same, but there are two types. And one is called reversible dementia. This type of dementia can be changed, or more importantly to remember, reversed. And that's why we call it reversible dementia. It can be reversed or gone back. The resident that you work with will be able to return to normal if they have a reversible type of dementia. But the other type of dementia is called irreversible. And this type of dementia cannot be reversed. A person with irreversible dementia will progress and will eventually worsen. And we'll learn more about that. Dementia can cause the loss of the following mental abilities, and I'd like to talk about that, and maybe you can help me think of some examples for some of these things. The first thing is impaired short and long-term memory. And I'd like to first talk about short-term memory, and maybe you can think of an example as I'm telling
sure
about that. The short-term memory is something that might have happened an hour ago or even yesterday, but it's something that was in the recent past. Can you think of an example maybe for that?
Well, I'm doing this all the time. It's I take off my glasses and put them down, and then I run around the office wondering where I put them.
I think I remember you doing that just yesterday. The other type of memory is called long-term memory, and these things happen longer in the past, or maybe from a person's youth or childhood. And these will be this type of memory, this long-term memory, will be the last to go in a person. In other words, a person first will show deficits in that short-term memory, that memory of an hour ago, or like you were just saying with the glasses. But the long-term memory will be intact or with a person until very late in the stages of dementia. The other loss that we see when someone has dementia is the loss and the deficit in impaired thinking abilities. And what that means is areas of understanding, reasoning, judgment, and difficulty learning new things or new tasks. And when we're working with older adults with dementia, we need to remember these areas and know that they may not be able to remember how to brush their teeth or comb their hair even. They may not be able to make the best decision making. And for instance, if they're being asked to purchase something from a salesman, they may not make the best judgment and may be taken advantage of. And unfortunately, we know in today's world, there's folks that prey on these folks. And finally, we see impaired language skills and communication. Can you think of an example of maybe that a person that has dementia and has problems with their language skills or communication?
Well, a person might hear what you're saying but not respond appropriately. You may be telling them it's time to eat, and they aren't getting up and following you because you've said it's time to eat, and they don't know that the first step is to get up and walk into the dining room.
That's a good example. One of the other examples that I think of often is a resident that I worked with that couldn't think of the name of a particular food item. It happened to be Jell-O, and he would call it jiggler all the time and ask for jigglers. And in fact, he was asking for Jell-O and just couldn't think of that word.
Sure.
So we need to be real creative. I'd also like to tell you about some other changes associated with this loss of mental abilities in dementia. And these might include personality changes. We might see a person that was always very kind and considerate, gentle, begin to use vulgar language, may begin to just act out and just not seem the way they were before. That might be a real sign of dementia. The inability to do activities of daily living. Maybe you can give us an example of that.
I think this is a real important example because when the dementia, when the confusion or thinking problems start to interfere with activities of daily living, things that we're used to doing, then we have to start being concerned. An example might be somebody who's dressing inappropriate for the weather. If it's 90 degrees outside and they're still wearing a sweater, or if they're walking outside in the winter without putting a coat on. Not using good judgment that way, and something that should be just part of normal living.
Right. Things that they did all their life and knew that was right and wrong. Good. Changes in how the resident interacts with others might be another sign. For example, somebody might become paranoid or suspicious of one of their fellow residents, or one of the coworkers, or one of the workers or caregivers that's caring for them. They may begin to say to them that they're stealing their prized possessions, their favorite quilt that they had on the bed, or a favorite item in the room. All of a sudden they're suspicious that people are stealing from them, or poisoning their food. If you're a caregiver and you're trying to give somebody some medication, they may claim you're trying to poison them or give them some medication that's going to kill them or hurt them.
This occurs in families too, that the person who has the dementia symptoms may be accusing their loved one of stealing from them or lying to them because they realize something's wrong and they don't want to admit they have the problems. They'll often blame it on somebody else.
Right. And then finally we see some confusion and disorientation. And this means that a person doesn't realize the person, the place, the time. They don't realize that it's really morning when in fact it's afternoon or vice versa. They may wake up from an afternoon nap and think it's morning time and ask for breakfast. They're just disorientated to that time and place. They get lost often because they walk out of the CBRF and they look back and they don't recognize that as home. In their mind, home might be their childhood home. And I think it's important in working, and I just want to mention this, that when working with these folks, it's important to go with them, I often say, into their world. Their world is very different than ours. And they may be in a world in their youth. They may be living in the time when they were 20 years old and are caring for a family. And we need to help them by knowing that this is okay to be in their own world and just validate what they're talking about. Can you think of any other ways that we might help them in that way?
Well, I think it's important to remember that what they think is real to them, and they're never going to accept what we see as real. So what you said is right. We need to enter their reality.
Yeah, good. Barbara, would you tell us a little bit about the other type of dementia, the reversible dementia?
Right. Reversible dementia can be changed. It can be reversed. It can be reversed. We can go back and make this person, if not normal, more normal in their function. And it's real important that we are aware of that, because we as the caregivers can change that. So let's talk about that for a minute. Reversible dementia can be the result of many things, and one can be as simple as a lack of sleep. I'm sure you've had experiences where you haven't had a lot of sleep or enough sleep one night, and getting up the next morning is more difficult. And you may feel even a bit demented because you're not thinking as quickly as usual. You may forget that you were supposed to pick up somebody because you're rushing around to go where you're going.
Absolutely.
So when it's real important to recognize that people need their sleep, they need regular hours of sleep, uninterrupted sleep, and we need to provide that for the residents that are living in a CBRF, because we can lessen their confusion or their dementia by making sure they get enough sleep. Stress or anxiety can cause dementia symptoms, and we can also reverse that. You've got a good example would be somebody who was just admitted to a CBRF. Can you think what that would be like for a person, John?
Well, when you think of all the changes that they must be experiencing, they've been removed from probably very familiar surroundings, their home environment, and now they're in this strange environment. I think if any of us have ever been in the hospital, we can relate to how that feels to just be removed.
Right.
It's
or
very scary.
Even on vacation, in somebody else's home, it's more stressful. So what we can do, particularly in a new situation like that, is make this place that they're now living, the CBRF, look more like their home. Have the family bring in furniture or their bedspread they're used to, and pictures from home and things like that, reducing their stress and therefore reducing their anxiety and therefore reducing their confusion. Many times we think, oh my gosh, this person really is confused. The family didn't tell us about it. And it could be just that now they're under a lot of stress. They're not used to having so many people around them. Something else that can cause symptoms of dementia that we can fix is pain. If people are in pain, they're often, particularly older people, maybe confused or irritable. Many of us, when we have pain, are irritable. And we can maybe prevent the pain, and if not prevent it, at least be aware of the fact this person has pain. And probably a really good example is older folks have a lot of chronic pain associated with arthritis. And if you hurt all the time, you might be real distracted, not paying attention when people are talking to you, and could be assumed to be demented, when in fact all you are is hurting. So if we could talk with a doctor and maybe treat that arthritis pain, then maybe they'll be more comfortable and not as demented. Another form of pain is constipation, and that's why it's important that we record when people are having bowel movements, that we provide nutritious meals with fiber in them so that they do have regular bowel movements, and we can avoid that pain of constipation.
I remember my grandma always had a bowl of prunes every morning.
Right, and so she was preventing dementia there.
Right.
People who have hearing and vision loss are often misdiagnosed or mislabeled as being confused, when in fact they just may not be seeing well, or they may not be hearing well. So it's real important that older people wear their glasses, that they have eye exams, so that they're seeing as well as they can. It's important that their hearing aids work, that they have batteries in them. It's important that we slow down when we're speaking to them so that they can understand us. We have to recognize that this is part of the normal aging process, and it'll probably never be as good as it was when they were younger, but we can help them be less confused if we compensate for the losses they've got.
Right, right.
Other things we have to think about with reversible dementia is that when people have, particularly older people, have a serious illness, whether it's diabetes that they live with all the time or they're coming down with the flu, one of their first symptoms may be confusion or irritability. We don't want to assume that this person is getting demented, that they have an irreversible problem, when in fact it might be something with treatment can be made better. A good example might be diabetes. You know, somebody's sneaking food from one of the other residents,
Right.
or the family's bringing in food that
Sure,
they're
sure.
eating. And we need to be alert for those kinds of things. When we see confusion, we need to think what else might be happening here.
I think that's such a message of hope that you as a caregiver can make a difference by possibly reversing some of these horrible symptoms of dementia.
Right. It's real important, too, that we recognize medications can cause symptoms of dementia, confusion, withdrawal, sleepiness, agitation, whatever. And we need to make sure that the doctor knows all the medication the person is on, so that they aren't counteracting each other or potentiating each other, making them act stronger than they really are. Because we can change medications, we can lower the doses, we can change the doses, we can change the medication and make the dementia symptoms go away. Something real important here that we need to talk about is depression. A lot of older people actually have depression, which is a treatable disease, and they're mislabeled as having something like Alzheimer's disease. And that's unfortunate. The symptoms of depression look so much like Alzheimer's disease in the early stages. It interferes with their thinking ability. Maybe they'll be less independent. They sort of withdraw and need people to take care of them. They've experienced a lot of losses, and so this is fairly common in older people, but we can fix it.
When you think of all the changes in the life of an older person, they're losing their friends, their spouse many times, their family, they're losing their independence. We just talked about moving from their home to a strange environment, to a CBRF. That's a big loss.
Absolutely.
And those are all, like you said, causes for this depression.
It's important, too, that they get enough fluids, because dehydration can cause symptoms of dementia. And with older folks, particularly in warm weather, if we see them more confused than usual, we need to think about how much have they had to drink. What have we offered them? Are we giving them things to drink that they like? And is it available for them so they can get it when they want it?
Right.
That's real important. And then we have to think, too, that sometimes older people will have small strokes, or TIAs, transient ischemic attacks. That's a big word, but we need to think of them as small strokes, not the kind where you're paralyzed on one side and you fall over and you can't speak, that sort of thing, but where you may see weakness or dizziness with the person and they're okay again. During that time, they may act real demented and confused, but it's usually just transient, meaning that it just lasts for a short time and it can get better. We'll talk more about how it sometimes doesn't get better, but it can come and go. And we need to talk with the doctor about this so that he can treat what's causing those small strokes and they will stop happening.
How would a caregiver maybe notice the first signs of these TIAs or these small mini strokes?
Well, the person's speech may be slurred.
Okay.
They may be trying to tell you something and they can't think of the words, and that's not normal for them. They may be dizzy. They may actually fall over. Because they're dizzy, they may be weak on one side, so their eyelid droops and their mouth droops.
So it's maybe just not as severe as a major stroke might appear.
Absolutely.
Okay.
Yeah. Why don't you tell us a little bit more about irreversible dementias?
Okay, I'd be happy to. Well, as I mentioned earlier, Barbara, irreversible dementia is the type of dementia that can't be reversed or can't be necessarily helped, or the person can't be brought back from the damage they're having. I'd like to tell you about some of the things that cause irreversible dementia. You mentioned the small strokes. These can also cause a type of dementia that is progressive, that does get worse. And this type of a dementia is called multi-infarct dementia. As you said, there's many different long words associated, and that's not so important, but it is important to know that this irreversible dementia is caused by many mini strokes and is progressive, does worsen in the person. It also, this irreversible dementia can be caused by a severe stroke or a major stroke. It can be caused by severe infections, and I'd like to give you a couple examples of those infections. One might be called encephalitis, and that's an infection that happens inside the brain, causes kind of a fluid buildup within the brain. Also, infection is AIDS, and that's become very prevalent. We see many people affected, and that can cause, in the end stage of AIDS, irreversible dementia, or those dementia-type symptoms we've been talking about. And then finally, there are some diseases that cause irreversible dementia. And a couple of the more popular ones are Parkinson's disease. We've seen that affect some celebrities. Of course, Katharine Hepburn is another famous person that we see. And the other popular disease that causes irreversible dementia is Alzheimer's. And of course, we see some celebrities affected by that, and probably the most notorious is President Ronald Reagan, who's now affected by Alzheimer's disease. It's important for you to know that all of these diseases are diseases of the nervous system. They do affect the nervous system within a person. And in most of these nervous system diseases, the physical changes will be noticed first. As we see with Parkinson's, we see the kind of the shuffling of the feet and a little bit of the tremors and that sort of thing. But as the disease progresses, we see the loss of mental abilities, and we also notice in the later stages, as I mentioned, that loss of mental abilities. Alzheimer's disease is the most common form of irreversible dementia, and it actually accounts for 50 to 60% of all of the types of irreversible dementias. So we can see that's quite prevalent. And as you're going to talk about next, Alzheimer's disease has a gradual beginning and gets worse with time. And will you tell us a little more about that?
I'd be glad to. Alzheimer's disease attacks the brain and results, like we've been saying all along, talking about dementia, it will result in impaired memory, impaired thinking ability, difficulty communicating, and that's not just me talking to you, but also what I'm hearing from you, how I understand your words and respond to your words. And it also affects judgment, and usually judgment is impaired with Alzheimer's disease. We hear a lot of people having the diagnosis of Alzheimer's disease, and people often wonder, how does the doctor come to this conclusion? What's real important, and we need to stress to everybody, is that the doctor goes through a process of eliminating other things that could be causing the symptoms, some reversible things like we've been talking about. It's not an automatic diagnosis. The doctor, you don't want to take someone into the doctor who says to you, well, she's 80, what do you expect? It's probably Alzheimer's. It certainly could be, and the older this person is, the more likely it is, but it also could be something else. And until we've ruled out something else, we don't want to make any assumptions. So what the doctor will do is investigate what the family history is. Has there been Alzheimer's disease in the family or any other irreversible dementia? Because there are some irreversible dementias that we know run in families. Right. He'll take a medical history to see what other things might be happening to this person. Are they diabetic? Do they have heart disease? Do they have difficulty breathing? Have they been real anxious all their life? That kind of thing. They'll do lab tests, and these are very routine lab tests. They'll do blood tests to find out if the person may have an infection. A lot of older people are running around with a chronic bladder infection or even chronic pneumonia without the usual symptoms that'll show up in blood work. They'll check to see if this person could be dehydrated. Maybe they're not drinking enough, and that's why they're confused. They'll also check the chronic illnesses that they do have and make sure that they're maintained well. You know, is the blood sugar level good in the person who has diabetes, that sort of thing. And they'll do a physical exam, just like you and I would have if we went into the doctor to see what works and what doesn't work. Then there'll be some oral and written testing to determine if how the person is thinking. You'll hear this called neuropsychological testing, and what it means is they're just trying to test how this person is thinking. They'll also do something called brain imaging, and what they're doing is taking a picture of the brain, and there's a slide coming on the screen right now that shows something called a SPECT scan, and this is something that's fairly expensive and not available everywhere, but I think it demonstrates what happens with Alzheimer's disease. At the top of the screen is a picture of a normal brain. And what's happened here is the doctor has put a sugar solution into the person's blood vessels, and the brain needs the sugar, so when the sugar gets to when the blood carries the sugar to the brain picks it up so that thinking can occur. And you see lots of color in that top picture because there's lots of healthy cells and lots of thinking going on. In the lower left picture, you'll see less color, therefore there's fewer healthy cells, and the brain isn't able to think as well. It's not able to pick up the sugar, so it can't think as well, so you see less color, less activity. In the lower right corner of this slide, you'll see more severe dementia, more severe brain damage, probably later in Alzheimer's disease, where there are more cells that have died. They cannot pick up the sugar, therefore thinking cannot occur. I think this is a real good graphic of what happens during the disease. If the doctor was looking at this and saw the pretty colored picture of the brain and saw black spots all over it, sort of like Swiss cheese, that would be more indicative of early Alzheimer's, because it's not just one spot that's affected, but it's all over. It's real diffuse. It spreads all over in little areas at a time.
Barbara, why couldn't a family member just have the doctor do this brain imaging that you're talking about and know that the person has Alzheimer's disease?
Well, it needs a specialist to interpret a test like that.
Okay.
Any family doctor can go through this protocol, go through these tests to find out other things that are wrong with the person. And even a specialist will do these same kinds of tests and will say, if you can't find anything else wrong, it's probably Alzheimer's disease.
So again, you're ruling out these things that might cause the reversible dementia that you were talking about earlier.
Right. The doctor may actually order a brainwave test, an EEG, might order a spinal tap, and even could send this person to a psychiatrist if you felt there was something else wrong that a specialist would need to see them for.
Okay. So it might be a group of specialists or doctors that might actually diagnose or, okay.
And when they go through the series of testing and the series of examinations, they're usually right 95% of the time.
Really?
When after death, an autopsy is done on the brain, and they look at it and they see the hallmark signs of Alzheimer's disease. So it is important to go through this process of ruling things out. The damage that occurs in the brain and what they see at autopsy are called plaques and tangles, and I believe on the screen right now will be some pictures of this as I'm speaking. They're hallmark signs, and when they see these in the brain tissue after death, they go, aha, it was Alzheimer's disease, we were right. What happens in this disease is the brain cells get sick and they die much more rapidly than normal. We all lose brain cells every day as part of normal aging, but with Alzheimer's disease, we lose them much more rapidly. The connections break down between the cells so that the cells can't communicate with each other. The ones that are left, try real hard, but they can't communicate the way they should, and so they can't compensate for the ones that they've lost. And then it's another thing that's real important to know is that the chemicals that help the cells communicate with one another are called neurotransmitters, and some of those are lacking. There's not enough of those, so that even that is impaired, even that doesn't work right. And the few cells that are left, again, can't communicate because those chemicals aren't there. There's going to be on the screen right now a cartoon of what the brain would look like if we could look inside of it, which of course we can't do while we're alive. But this particular cartoon shows extension cords within the brain. And I always think of Christmas trees when I see this particular slide, because if you had a Christmas tree and somebody tripped on the cord, what would happen to the Christmas tree?
Well, your lights would go out.
Right, the lights would go out, and that's much like what happens in Alzheimer's disease. It's like somebody's pulled the plug and the lights go out in that particular part of the brain.
I think sometimes families even say that to us, that it looks like the lights have gone out. They look in the person's eyes and they just don't see that spark.
Right, it's just not there.
I wish we all could have this guy up in our head making more connections.
Right, plugging it back in. There are some theories on what causes Alzheimer's disease. It's an important thing to know that we don't know, and there's lots of theories about what causes it. The newspaper will often say that they've discovered some new wonderful thing, and indeed they have, but it's only a theory at this point. The theories include environmental poisons. We're living longer now, so we're in contact with some of the things that are in our environment for a longer period of time, and that may be affecting the brain. There may be a genetic influence. It may run in some families. There's a possibility, a remote possibility, that there could be a virus or a slow-acting infection in our body that we've carried for a long time that kicks in later in life. There is another irreversible dementia that works that way, so could Alzheimer's disease be that way too? We don't know yet. And also they look at the possibility that the body's ability to fight infection has been impaired. Instead of fighting germs that will harm us, it now starts fighting normal cells that are doing us good. So they're looking at lots of things, but they don't know yet. There are some treatments, even though we don't know what causes it, there are some treatments. And the things that you and I do and the people that are watching this tape can do are probably the most important treatments for this disease. We can create special living environments for people with Alzheimer's disease, and many CBRFs are designed to do just that. What kinds of things would they include in that environment to support the person?
Well, I think you mentioned earlier, just making that a home-like environment, just making that CBRF look more like maybe what they came from versus this institutional-looking type design. Inviting them to bring in some of their furniture maybe that they had in their own bedroom, maybe a quilt that they had, their favorite quilt, making the noise level and the lighting more relaxing to those folks. So those are just a few things I think you could easily do in any CBRF.
Right, and it's real important that staff are trained, that they know about the disease, that they know how to communicate with these people, that they know how to deal with families, because families have been living with this disease for a long time, that they understand the importance of meaningful activities for this person, that if this is a person who's been sweeping the floor and folding laundry all their life, or a person who's been balancing the books all their life, that they need activities that will be meaningful to them now that they used to do before, things they can plug into with their memory.
Sure.
So those are real important things that the caregiver can do to treat this illness. There is nothing specific to do, and it's very individualized for that person. There is one medication that's available now to treat this disease, but it only helps people in the early stages. And because we can't diagnose it accurately, we don't know who to give it to. And it doesn't seem to help very many people, and it's fairly toxic. But it's brought hope to families that can use it, and it's important to know too that there will be more medications soon, perhaps acting just like this medication but not as toxic, so it can help more people. And then they're looking at other things and other ways that drugs can help. Research continues, because what we're looking for is, how do you diagnose this disease? Can we slow it down? It would be great if we could cure it. One way to think about this disease is to equate it to diabetes. Years ago, when that diagnosis was made, people just assumed they'd be dying soon because it was a fatal disease. But now we have a treatment, not a cure. If you've got the disease, you've always got it. But we can treat it so that you can live a pretty normal life. And the hope is that we can find a treatment so that people with Alzheimer's disease can also lead a pretty normal life. John, I think we need to explain how this disease progresses over time.
I think it's important, especially when folks are working, when caregivers are working in a CBRF with people affected by Alzheimer's. It's important to know that Alzheimer's disease is a progressive disease. It will worsen, as we said. And many times we'll hear stages described for the disease, and you might hear, and you've probably heard some of these stages, Barbara, there might be 3 stages, there might be 7, there might be 10, and that's really not so important how many people say their stages, but to know that a person will progress through what seems to be some stages. And today we're going to talk about 3 stages, and that's the early, middle, and late. Those are the 3 that we're going to describe. Alzheimer's disease can last anywhere from 5 to 20 years, depending on when it was actually diagnosed in a person. And each person will exhibit symptoms at different times. And I think the important message, as you've mentioned, is that Alzheimer's disease is an individual disease. It affects everyone differently. There's no one way that it affects people, and it's important to know that, and know as we're working with these folks that just because Mr. Jones and Mrs. Jones both have Alzheimer's disease, they're not going to progress the same way. So let's talk about the early stage. At the early stage, a person might still be living alone independently in their home. They might have a primary caregiver that lives with them, but they're still living pretty independently. They might have some mild forgetfulness, mild memory problems. I talked about that memory of yesterday or an hour ago, that they might be having problems with. You may ask, did you send in the check for the electric bill? And they just did it last night, but they don't remember doing it. Difficulty with newer complex tasks. Paying the bills is another task that is pretty complex for us. Balancing your checkbook might be another. And something that they always did very well at, now they're beginning to have problems with. And if you introduce a new task to a person in the early stages, they may have difficulty with that. And then finally we see a social withdrawal, kind of a lack of initiative. The person just doesn't seem to want to get involved in anything any longer. They've kind of given up. And I think when you talk about depression, this early stage of Alzheimer's disease often has depression associated with it.
Right. Or it certainly looks like depression sometimes.
Right. Barb, will you tell us about the middle stage of the disease?
Sure. I think it's interesting, too, about the early stages, that families often don't know it's happening as it's happening. As they look back after the diagnosis is made, they'll say, oh, Grandma hasn't planted her garden for a couple of years, or Mom hasn't made those cookies, or whatever. So the early stages are often identified better after the diagnosis is made than when they're going on.
Very true.
By the time they're in the middle stages, they're starting to have more and more problems, and they should not be living alone most of the time. Sometimes they go to live with their families, or they may actually move into an assisted living kind of facility like the CBRF. In the middle stages, the person is more disoriented to time and to space. A good example of this might be, like you were saying before, they may take their medication and forget they've taken it, so they take it again. And now they're overdosing with medication they should be having, but they're taking too much. Or maybe they can't remember if they've taken it, so they'll take it, or they'll take another one. They'll mistake one for the other or whatever, but they make mistakes with their medications. Or they may not be able to find the bathroom. They may still feel the urge to go, know that they need a bathroom, but they can't remember where it is. Once they recognize the toilet, they know what that's for.
Sure.
They can toilet themselves, but it's finding their way to it. They also have more language disturbance, where they'll have more difficulty understanding the caregiver's words. They have more difficulty making choices. The wife may say to the husband, honey, what would you like for dinner tonight? And that's an abstract thought, and you and I might have all kinds of thoughts in our mind about how to answer that question, but it might be real overwhelming to come up with an answer to a real abstract thought like that.
What do you mean by abstract?
Good question. I guess abstract is when it's not real obvious to you, and if the woman had said to her husband, would you like lasagna or a hamburger for dinner, he can picture those two things are more obvious. But if she just says, what would you like, then he has to come up with decisions, and it's more abstract. It's harder to think about.
Okay.
They'll need more supervision. Their judgment is more poor. They may have been cooking at home alone, but they don't recognize green stuff growing on food in the refrigerator as mold. They may put something on the stove to cook and forget that they've left it there. It starts to burn. They smell smoke, but they don't recognize it as a danger, and so don't respond to it, and a fire may actually start. And then agitation may occur in this middle stage. And a lot of times I think it's because they're so overwhelmed by all the other things they can't control. I mean, it's real frightening to know that you don't feel comfortable in a place you've lived in for 40 years. It doesn't look familiar, and the people around you don't look familiar. And you're not able to do things that you could do before. So you often will see agitation in the middle stages.
Well, and finally there's the late stage of the disease. And at this stage, the person needs total care. They're not able to meet any of their own needs, and the needs must be met by a caregiver. At this point, many times folks need to be moved to a nursing home type environment. They're not able to stay in that CBRF any longer. And I think it's important at this point that caregivers anticipate the needs of the person with Alzheimer's disease. In other words, that person's not going to be able to ask for a glass of water. They may know they're thirsty, but those connections, those extension cords aren't connected enough to say, can I have a glass of water? So the caregiver needs to say to that person, would you like a glass of water? Do you need to go to the bathroom, like you had just mentioned too? Or
even taking them to the bathroom, because when they see it, they'll know what to do, or giving them the water, because the water will be the cue that says, oh, I could drink.
Exactly. And I think the goal at this stage is to make the person as safe and comfortable as possible. It's really all you can do at this stage is to just make sure that person still has some quality of life as much as possible. Around-the-clock care is needed. Verbal communication is very limited at this stage. The person may only make noises rather than actual words or phrases. They may still recognize the people very close to them, but they may not recognize the grandchildren. Or you as a caregiver, even though you worked with them for many months and you saw them yesterday, you'll come in today and they may not know who you are. And that's definitely a part of this disease and this stage. They're incapable of self-care of any sorts, and they're incontinent, which means that they're not able to control their bladder or bowel any longer. And they usually need some protection to wear because they're just not able to hold even their bowel and bladder. Alzheimer's disease, unfortunately, ends in death, as we know. And usually that death is caused by an infection, such as pneumonia. The person's so weakened that this pneumonia takes over their body. And you and I might be able to fight off pneumonia, even though we'd be very sick. We could fight it off and get better. That person's in such a weakened state that they can't fight it off, and they die from that. They may not be able to drink or eat any longer, and because of that lack of foods and fluids, they also would die. Barbara, why don't you tell us a little bit about some suggestions for the caregiver?
Well, it can be real challenging to work with folks who have Alzheimer's disease. It takes a real special person to do it. And for those people who are doing Alzheimer's care, which we call special dementia care, it can be really rewarding. Caregivers, as I said, have to be special. They need to be compassionate people. They need to be flexible. They certainly don't get to do things their way all the time. And they certainly need to have a sense of humor. Sometimes that's what keeps us going. Caregivers need training and they need support so that they can do their job well and so that they can enjoy it. When caring for someone with Alzheimer's disease, it's important to remember to treat the person with dignity and with respect. This person may be acting just like a 4-year-old, you know, but this is an adult. This is perhaps an 80, 85-year-old person who's had a long life, a meaningful life, where he's been respected in his position and in his community. Even at the end stages of the disease, when they're no longer able to understand our words, we need to keep speaking to them because they will be able to understand our tone of voice and our touch and that sort of thing. So we want to always treat them with dignity and respect, and to help them remain as independent as possible. We want to always stress what they can still do, not focus on what they can't do anymore.
Another thing that we can do is get to know the resident as well as possible and know their past. And I think we can get that from the family, if possible from the resident themselves, from friends. Learn their likes and dislikes, and that can help so much with caring for someone with Alzheimer's disease. If we know what foods they like, they may eat better because we have given them foods that they do like instead of giving foods they don't like or dislike. Learn what their triggers are. Learn what might set them off as far as a behavior. Knowing that pets really aggravate someone, or knowing that asking too many questions at once really triggers this person and makes them angry. And that can be learned from family, from that primary caregiver that has been caring for this person for so long.
And if I've been eating my breakfast in my robe every morning, don't expect me to get dressed for breakfast. You may have difficulty just because you didn't know that about me.
Exactly.
And it's important to use good communication skills, and one of the future tapes will talk a lot about how to communicate with people with Alzheimer's disease. It's real important that you know that your communication is important with these people, that your verbal as well as your nonverbal communication is important. That we don't argue, as we talked about earlier, that their reality is their reality, and if it's not ours, we don't argue with them. We're not going to win. We need to validate their feelings so that they're comfortable. And I think we need to also remember that touch can be used appropriately as long as we know this person and we know how to use touch appropriately with them.
And then finally, you mentioned earlier being flexible, resourceful, and creative. Problem solving with coworkers, with your fellow caregivers, can be real powerful. And I think we can lean on our fellow workers and our fellow caregivers for support, because it can be pretty stressful to care for somebody with Alzheimer's disease. And you need to really hang together as a team and work together. Share what's worked and what has not. We talked about learning from the person's past of what likes and dislikes, but also learning what has worked for another caregiver in the CBRF, and then do that same thing so that you don't have to learn yourself. Share that information. And be in tune with your own moods. Barb, we all have certain moods. Sometimes we're depressed, sometimes we're angry, and people with Alzheimer's disease seem to be almost more in tune with those moods. And I always use the count to 10 rule. Before you go into the room, do that 1, 2, 3, all the way up to 10. Kind of calm down a little bit, especially if you're angry or upset or depressed, and reframe yourself so that you're ready to go in and really do a good job with that resident with Alzheimer's disease. Now it's time to turn off your videotape and complete the Part 2, What is Dementia post-test in your workbook. Welcome back. Now let's review the answers to your post-test. You may turn to the post-test responses in your workbook if you wish. Number 1, dementia can cause the loss of thinking abilities. That's true. Dementia can cause a loss of short and long-term memory, and it can impair in thinking abilities and language and communication skills.
Number 2, irreversible dementia is the kind of dementia that can change and the resident will usually return to normal. That's false. Irreversible dementia cannot be changed and the resident generally will become worse with time.
Number 3, poor vision, a hearing loss, inadequate fluids, or even a lack of sleep can cause reversible dementia. That's true. All of these things can cause reversible dementia.
Number 4, many small strokes may cause irreversible dementia. That's true.
Number 5, Alzheimer's disease is the most common type of irreversible dementia. That's true. As I mentioned earlier, 50 to 60% of irreversible dementia is caused by Alzheimer's disease.
Number 6, when a resident has Alzheimer's disease, the caregiver will notice that their thinking process is not what it used to be. They have memory loss, poor judgment, and difficulty communicating. This is true. It has a gradual beginning, and it will get worse with time.
Number 7, Alzheimer's disease is diagnosed by ruling out other causes for the change in the person's thinking ability. That's true.
Number 8, people with Alzheimer's disease will always have the same symptoms. That's false. Alzheimer's disease is very individual in each person. In other tapes, you will learn how to communicate with people who have Alzheimer's disease. You'll learn how to adapt their environment and how to create meaningful activities for them. The things you do as a caregiver to create a meaningful and a safe environment are the most important treatment for people with Alzheimer's disease. Thanks, John. This has been fun.
Thanks, Barb. It has been a pleasure. After you've turned off your videotape, take a moment to fill out the activity, I have Alzheimer's disease. It's located in your workbook. After you've completed it, take time to talk with other caregivers about your answers. There is hope for those affected by dementia. You are that hope. Do all you can to keep learning about the disease. Help others to understand it and to take it seriously. Know that you can make a difference in the lives of those affected by dementia. This concludes Part 2, What is Dementia? Thanks for joining us.